Afternoon to all who are here in the room, and hello to everybody who is participating online. We understand that the signal is already on the live stream, and we had quite a high number of people registered for the event. Welcome to this event with the title, The Time is Now, Improving Access to Diabetes Care in a Strengthened Global Policy Framework. This is an official satellite symposium of the IDF World Diabetes Congress taking place this week here in Bangkok at the conference center where we're all together. My name is Bent Lautrup Nielsen. I'm head of global advocacy with the World Diabetes Foundation, and I'm co-moderating the session on behalf of the World Diabetes Foundation. And here is my co-moderator.
Hello, everyone. It's a pleasure to be here. So hello to those attending in person. Thank you for your time. And big hello to those attending virtually. Good morning, good afternoon, good night from wherever you are joining us from. Thank you for your time. My name is Jackie Malouf. I am a vice president with the International Diabetes Federation, founder and president of Dialab, the National Diabetes Federation in Lebanon, organization, not federation. I'm so used to IDF by now. So it is a pleasure to be here, and even more pleasure to be witnessing this collaboration between the International Diabetes Federation and the World Diabetes Foundation. It's about time. So when we say the time is now, we are not saying a slogan. We are implementing it by starting a strong collaboration where you are witnessing tonight this first collaboration being on the ground. So it's a privilege actually to welcome all of you to this critical discussion at a very pivotal moment as we witness IDF turn 75 years. It is indeed a milestone, and we are showcasing it through this strong collaboration. More collaborations to come, you will see throughout the panels.
And we have a very compact program, many speakers from all parts of the world. So we will not waste so much more time for introduction. We will go to the opening remarks.
So it is a great pleasure to call to the floor Dr. Niti Pal, the very brand new President-elect of the International Diabetes Federation. Niti, the floor is yours.
Thank you, Jackie, for that very generous introduction. And Jackie, I count on you as one of my friends.
Thank you.
We have two things in common. We're both working for diabetes, but we have a child each, almost the same age with diabetes. I was joking with Jackie. I'm a type 3 diabetic. You may not know what that is, but that's who we are, the families of people with diabetes. I welcome you all to this great seminar, and thank you very much to the World Diabetes Foundation for collaborating and partnering with us. It's a great honor and a great privilege to share the stage with you and to share this advocacy forum with you. The time is now. We can't really wait for this policy change to happen. The reason I think it's very important for us, and we have a lot of strengths, and obviously the World Diabetes Foundation has lots of strengths, we work across many, many regions, all the regions of the world, and the WHO Compact has been released. People understand that diabetes is a marker for good treatment of any NCD, not just of diabetes, so we understand that too. And during COVID time, actually, we asked all governments to look at diabetes care as a marker for what was happening to NCD care during COVID. And you all know what happened during COVID to NCD care. So I think that is the time. That time is now. But we do have a lot of member associations. I have had the privilege of serving on the IDF Europe board for over 7 years. And I know that there are many member associations here from IDF Europe. And the only way that you can advocate and the only way you can put policy into practice is through member associations. It's not through umbrella organizations. It is through member associations. It's through the regions and the regional bodies. That's where these things happen. So we're delighted to be here with you, World Diabetes Foundation, and we're delighted to be partnering with you. we bring to you an umbrella organization that covers all the regions of the world, with diabetes voices that are present everywhere. And the voices are both people living with diabetes and the professionals that treat them. Thank you very much for your attention, ladies and gentlemen. See you soon.
Thank you.
On behalf of the World Diabetes Foundation, I would like to invite our chairman of the board, Dr. Anil Kapoor, to give welcoming remarks. Please, Anil.
First of all, I'd like to say congratulations to Madam President-elect of the IDF, and I look forward to a strong collaboration in the coming years. The World Diabetes Foundation is not that old as IDF, but I personally have been attending IDF conferences for the last 35 years, half of my age. The World Diabetes Foundation is only about 23 years old. And I can say that it has always been our effort to work with the International Diabetes Federation. In fact, our very first initiative that we did was Diabetes Action Now. And I'm sorry that after 21 years, 22 years, we are again talking about the time is now. The Diabetes Action Now initiative was a collaboration with IDF and the WHO, and it created a massive initiative around advocacy for diabetes. Subsequently, we have been supporting the IDF Diabetes Atlas and several other initiatives in the developing world. And unlike the IDF, we only fund initiatives in the developing part of the world, which we believe needs our assistance much more. If you look at our programs over the last 20 odd years, 22 odd years, we've funded over 600 initiatives in over 100 countries around the world. Many of these initiatives were pilot, but these initiatives empowered the people who were putting these efforts to take them to a higher level. And we are now starting to see, after 2 decades, that these initiatives are turning into national level programs. And I must say that in all these initiatives, it has been our endeavor to partner with patient organizations, professional organizations, wherever they are. I'm actually quite proud to say that the World Diabetes Foundation has paid attention to some of the most important areas in the area where diabetes therapy was lacking. For example, some of the first initiatives was on diabetic foot, needless amputations happening because of diabetes. And this was a large initiative which has been replicated in several countries. We took up the initiative around preventing blindness, unnecessary blindness because of diabetes, and large efforts were done around that. We were amongst the first to link up with maternal health and NCDs by our initiatives around hyperglycemia and pregnancy. Not only did we work with the IDF, but we have worked with FIGO. And we have tried to get FIGO and IDF together to be able to talk about taking action around this area. And I must say that today we also discuss about diabetes and tuberculosis. And in 2011, when the collaborative action between the International Union Against Tuberculosis and Lung Disease and WHO happened, the matchmaker was the World Diabetes Foundation. We were sitting behind, bringing the organizations together to get things done. So it's not often that we talk about who we are and what we have done, but it is our effort always, because we believe that any program on a large scale can only be successful if there is local buy-in, and that can only come through patient association and professional organizations in the given country. Another important aspect that we have worked on is the fact that we have empowered our local partners to be able to seek funding with other agencies. And I think that's a very important fact, that when we talk about lack of finances, that we have been able to empower our partners to be able to access development assistance, to get assistance from other organizations to co-fund the initiatives that are happening on the ground. And in the last point that I would like to make is that while the International Diabetes Federation may not recognize it, but in many small countries around the world, our programs became the nidus for creating local diabetes associations. And so it's an immense pleasure for me that we have been able to come together again after a pretty long gap, because we were always together. When the World Diabetes Day initiative happened with Professor Martin Silling, I was sitting behind trying to help those in terms of resources, in terms of other network initiatives. We played a subdued role when the initiative UN high-level meeting happened on NCDs, and we continue to play that role of advocacy. So thank you very much to the International Diabetes Federation. And I must say thank you to my colleague Bent, who has been a fantastic advocate for the cause of diabetes, not necessarily the World Diabetes Foundation. Thank you, Bent.
Isn't it wonderful to see the organizations compete to help people living with diabetes? Isn't it wonderful? That deserves a big applause, right?
Thank you very much, Anil. We are now entering the session program. It will consist of 4 sections. First, we will have keynote interventions from the WHO and from a representative of the Blue Circle Voice. Then we will move to the first panel, which will be about national NCD and diabetes programs. The second panel will take a step into more regional and advocacy perspectives, and the fourth and final section will be a closing segment with reflections and plenary debate. We will ask all the speakers to be very mindful of time. We have so many speakers today. We wanted to give the opportunity for a lot of voices to be heard and shared here at the conference. Please, Jackie.
Thank you, Bent. It is with great pleasure that I will invite our next speaker, the keynote speaker, to the stage. But I would like to say that the International Diabetes Federation takes pride in working in alignment with the WHO goals and guidelines. So my pleasure to invite Dr. Guy Fownes to the floor. He is the director of the Department of NCDs with the WHO, along with many other titles. Our speakers have long bios. I invite you all to look at them because they have done a lot of achievements that for time's sake, we cannot read all their achievements. Dr. Fownes, the floor is yours.
Thank you. Thank you so much, Jackie. And good day to all here in person, and very especially to those joining online. This is an excellent opportunity to have a hybrid discussion, and hopefully we have some sort of engagement and comments from those online. Looking forward to hearing those insights. But thank you so much for the sponsors, IDF, WDF. I can legitimately call you traditional, long-standing partners of WHO. We've had great experiences, collaborations, and partnerships across many, many areas of the NCD and even beyond the NCD agenda. So thank you for the invitation and for the very, very important discussion. And the keynote speakers, Dr. Kapul, Dr. Pal, thank you so much for your opening remarks. I could not agree more. I think both of you pointing to the fact, and this is very much owned by WHO, acknowledged by WHO, as we move into supporting, as we have designed, developed this strengthened global policy framework, which I will comment on. We're supporting that, exactly strengthening the policy options, policy interventions for member states. But as we move into supporting regions and countries, we can definitely not do this alone. We need to count on our partners, count on the networks that our partners have convened, the power of partners, the power of lived experience, the power of youth, the power of young professionals as we move into understanding the contextual needs on the ground and how we can translate this global policy framework into action on the ground that is sustainable, equitable, and relevant to our communities. But then let me start my presentation by also aligning the first part of the title of today's session, which is Time is Now. And yes, Dr. Kapul, we've been urging that the time is now for some time now, but it could not be more important, it could not be more relevant as we move into a very important milestone at the end of this year, which I hope I'll touch on a little later. But let me go through a bit of what WHO has been developing, and not alone, by no means alone, it has been developed from the very start through a very multi-stakeholder, multi-sectoral approach. And I think this will be sort of also a very important thread throughout our discussions, throughout solutions that we identify, and throughout the next steps that are required to support our countries. It needs to be multi-sectoral, it needs to be multi-stakeholder, from design to implementation and to monitoring. So at WHO, my first slide here, I think we can start. The time is now. And I think we come back to this, and the time could not be more urgent. The call for enhanced attention, multi-stakeholder attention to the rising, acceptable rise in the global diabetes burden has to be addressed, has to be urgency. You'll see there at the far left of the slide, the latest of WHO's estimates, which identify that 828 million people as of 2022 are living with diabetes. This is extremely alarming, as it is a fourfold increase since 1990. And it's not only the fourfold increase, the accelerated progress of the NCD burden, the accelerated process of the impact on those living with diabetes, but it also is the realization that more than half of those living with diabetes, more than half, 60% almost, adults living with diabetes are not taking medications for. And of those that are not taking their medications, 90% of those adults are living in LMICs, low-income countries. This is a huge, huge equity discussion. It's a huge equity, health equity impact, undermining the ability of health systems to respond to the needs of those living with and at risk of diabetes, undermining the resilience of health systems, and it needs urgent attention. This has shaped the response WHO has been framing, designing, and developing for the last 4 years. I'm happy to provide some insights on the WHO Global Diabetes Compact, but also delighted to announce that we'll be celebrating its 4 years of action and 4 years of progress, 4 years of impact. There's much more to do, but this is where we count on that multi-sectoral, multi-stakeholder action. We count on the collaborations, we count on the networks on the ground to help shape those interventions for our communities. Just very briefly, where the genesis of the Global Diabetes Compact has come. It is in the attention of the time to act is now. It is on the attention of that growing burden of the diabetes, of the weight of diabetes prevalence on health systems. And this is WHO member states. This is our countries. And this is not WHO designing, deciding, or prioritizing the needed actions. This is convened at the WHO, the World Health Assembly, where the full force of the member states of WHO came together and understood this is the time to act. We need to request WHO to support us, partners to come on board through a multi-stakeholder action, and we need attention to very key areas, pain points, and gaps in the NCD response. That was developed and delivered through a WHO resolution, which is very important because that's a resolution that is consented, agreed on by all WHO member states. So it is a very, very powerful sign from our member states. Act, WHO partners, act now, act with urgency, support us, help us, and this is the roadmap that we need you to support us on. The resolution, very, very, very detailed resolution with very clear actions and tasks given to WHO and partners. A year after that resolution, in progress in understanding what the vision was for that action, for that convening of partners, and the advocacy around the gaps in the diabetes agenda, member states endorsed then the 5 global diabetes coverage targets you see there on the right. Very, very important to convene the partners, to convene advocacy, to convene attention, but also to start immediately as soon as possible by 2030, obviously, but even before if we can, and we have some success stories where countries are demonstrating progress even before that deadline of 2030. Across those very important targets, 80% of people with diabetes are diagnosed. 80% of the 828 million people living with diabetes need to be diagnosed by 2030. Of those diagnosed, 80% of those need to have good control of glycemia and should have good control of blood pressure. Of those living with diabetes over the age of 40, they also need to be receiving statins. And importantly, 100% all of the population living with type 1 diabetes need to have access to affordable insulin and blood glucose self-monitoring. Very clear, very precise, very important, addressing the pain points across the health system, delivery, the cascade pathways, and the service delivery pain points. And we'll maybe touch on some of those. We have the commitments from member states. We need your support on this. We have the roadmap, the vision. We need to reach these targets by 2030. How do we get there? The Global Diabetes Compact is there to exactly guide member states, guide partners in a very, very conscious, very deliberate, a whole of systems approach to addressing the diabetes impact. Then you'll see the 6 work streams that address that systems approach to respond to those living with diabetes. One is to understand better and promote and progress on the access to essential, quality, affordable diabetes medicines and associated health technologies. Very important, and I'll give a bit of detail, slight detail on that, as it is certainly part of our discussion today. But also a very important work stream that is WHO's key role: norms and standards, evidence-based guidance, science, the science behind the guidance, the frameworks, the interventions that will shape health systems at country level. And there's a very, very healthy portfolio currently already being developed, launched, but a very, very important pipeline of technical products, guidance, evidence, policy briefs that guide member states in their actions. The third is very important. We need to, first and foremost, prevent, promote healthy lifestyles, address the risk factors, the determinants that are impacting on that huge growth and prevalence of those living with diabetes. I would say the most important one is work stream 4. How do we convene all of our efforts around this policy discussion and policy implementation to support countries? How do we take policy interventions and translate them into impact on the ground, and not necessarily at national level? Very important, and that was touched on by our keynote speakers, very importantly, at the subnational community level. How do we address the contextual needs at community level across all of these areas? Research innovation, certainly underpinning all of our science and evidence generation. And the last one is something that also will be touched today, is the governance. How do we really ensure multi-stakeholder? How do we ensure collaborations? How do we ensure multi-sectoral approaches to the sustainable solutions that we are designing? A little bit of insights into workstream 1, which is so important for our discussion. How is WHO taking the lead on understanding the pain points on the access to essential diabetes medicines and technologies? Certainly, we have those 3 bullets. A very important one is that we are engaging with the private sector on ensuring that we have a collaborative approach with the private sector on improving access, affordability, fair pricing, procurement, and sustainability of insulin and associated health technologies. You'll see there a few examples of how we're delivering that. Private sector dialogues on how they can deliver commitments, they can define commitments that the industry will make to support public health measures on the ground. Pre-qualification is so important that we're moving forward on several pre-qualification streams that you'll see there, and then a technical brief on very important for LMIC countries and rural communities on thermostability of human insulin. And the others are additional sort of access discussions. We are just now proposing for the next WHO Essential Diagnostic List advice on personal use of glucose monitoring devices as part of the WHO Essential Diagnostic List. And there's an ongoing project, very important ongoing project on forecasting, NCD Medicine's forecasting and quantification tool. We are piloting in Ethiopia, and hopefully that we can scale that very important tool across other countries. Stakeholder engagement. This is probably also the golden thread across our discussion, and I see time is running out. And moderators, I'll resume quickly. Stakeholder engagement. Through the global platform, the global compact, we have very clear engagement opportunities across FUC. We have very clear
focus on how do we engage with member states through regions and our country offices, but ensuring that we're engaging with member states, understanding their needs, their priorities, and their gaps. We have technical advisory groups. We have a very important WHO Global Diabetes Forum, which convenes more than 140 partners, and I encourage you already to join this forum if you have not already. I know I see some familiar faces. Join the platform from organizations, from lived experience, and from communities. We have also a very important platform on engaging and empowering lived experience, and also, what I've mentioned, engaging the private sector. But this is the global environment, the global dialogue, where we convene our forces, our resources, and our attention. But then what do we need to do? We need to trickle, translate, and develop that into the regional adaptations and then into the country implementation. Regional adaptations happening across all 6 regions. For lack of time, I will just see that all 6 regions are adapting, implementing the Global Diabetes Compact in their own context, and with that, further supporting countries. And one example of that is a very, very important, really important project, Diabetes and Cardiovascular Disease Initiatives in Africa, the CCARD Africa, and I acknowledge our excellent collaboration with WDF on this. I will leave these slides there so you can have more access, but this is the ultimate end game. How do we support, how do we bring all this together, translate our policies into action on the ground, and how we contextualize it for the needs of our different populations? Just to land on 2 more slides, on the very important engagements platforms with civil society and our partners in the civil society space, but very importantly, in addition with our lived experience communities. And we at WHO have really walked the talk lately on the meaningful, productive, respectful, inclusive, representative engagement with the lived experience across the NCD agenda, and very particularly excellent demonstrations of how we're doing that within the diabetes program. But very much, and you'll see there are some initiatives that we also call on you to join us and join forces, participate. This is a real meaningful. We do bring you in on the design and development and discussions on policies, all the way through to the implementation and monitoring. And hope we can do even more through that. And you'll see there's some opportunities to engage on that. And then the global, a particular unit of the WHO is working further on this engagement opportunities, multi-sectoral, whole of government and multi-stakeholder. And that will be my last point. I think we need to, and especially across the whole NCD agenda, but very especially for the diabetes, we need to have a very clear focus on multi-sectoral. How are we working across government sectors? This is not a solely responsibility of health sector. We need to understand and we need to empower our health sector to be able to engage, sustain engagements, and identify those win-win opportunities across different government sectors for the benefit of our populations. And then the multi-stakeholder engagement of whole of society. How do we bring all relevant partners on board? And we have ample examples of how we're doing that. The 4th high-level meeting on NCDs. I can't continue without saying a few words on that. Such an important moment, and this is the time. Time is now to act, and the multi-sectoral elements have to feed into the 4th high-level meeting. We have done an excellent effort to include all the voices throughout the preparatory process for this meeting. There is clear attention to diabetes gaps in this new discussion in New York at the end of the year. There's clear attention to the voices of lived experience. There's clear attention to the voices of civil society, and there's very much clear attention to what member states are asking us to prioritize. All of that will feed into that September meeting, where we'll discuss NCDs and diabetes as a development issue. And I think the first slide touches on that very clearly. And I invite you to already engage in a pre-event before the September meeting, which is on the 2nd of May. It's a multi-stakeholder hearing where we invite all of you to raise your voices, raise the priorities, raise those nuances that policymakers at the global level don't have the necessary knowledge or expertise to identify. You do. Please ensure those nuances are well represented in the discussions in New York. And I will leave it at that. I leave you with some QR codes, which access many of our newsletters, our resources, the GDC forum itself, where you can join, and the GDC webpage, where you can find all of the resources I have mentioned and much, much more. Thank you so much, and apologies for spilling over.
We will send you the bill with the penalty amount for the extra minutes. Thank you, Dr. Fones. I'm personally looking forward to seeing the implementation of the support to the civil society. And here you have many representatives of the civil society. So I'm very pleased to share with you that we had over 2,000 registrants online. Thank you for that again. And we have now currently over 500 people online attending, other than all of our distinguished guests present here. Now, it is also my pleasure to invite Ms. Anita Sabidi, who's a Blue Circle Voices member. Please, the floor is yours.
Good afternoon, good evening, everyone. It is an honor to stand here today to speak about an issue that is deeply personal to me, access to diabetes care. As someone who has lived with type 1 diabetes, growing up and coming from a small tribe in Indonesia, I understand firsthand the challenge of managing diabetes in a world where access to essential care is not guaranteed. Diabetes is not just a health condition, it's a lifelong journey that intersects with human rights, social justice, and economic development. Despite medical advancements, far too many people still struggle to access life-saving insulin, medications, diagnostics, and education. I have seen this disparity not only in my own experience, but also through the countless stories shared within diabetes communities worldwide. The reality is that where you live, your gender, and your socioeconomic status can determine whether you thrive with diabetes or you suffer with diabetes. We live in a world where access to diabetes care remains unequal. In low and middle income countries, insulin and medical supplies are often unaffordable or unavailable. Even in high income nations, systemic barriers persist, particularly among marginalized communities. As a woman with diabetes, I have faced unique challenges. From navigating healthcare systems that often overlook gender-specific needs to balancing self-care with society's expectations of motherhood and caregiving. Health systems must be resilient and equitable. Diabetes care should not be a privilege. It must be a right. Yet, we continue to see access gaps, especially among women, children, and underrepresented communities. To bridge these gaps, we need a bold and inclusive global policy framework that first prioritizes diabetes in universal health coverage. Government must integrate diabetes care into national health plans, ensuring that essential medications, technologies, and consultations are covered. I know what it means to fight for access, not just for myself, but for the countless others who rely on consistent care to survive. Universal healthcare must prioritize diabetes as a fundamental public health investment. Second, expands equitable access to insulin and supplies. It is unacceptable that more than a century after its discovery, insulin remains out of reach for so many. As an advocate, I have witnessed the devastating impact of insulin rationing and the difficult choices people with diabetes are forced to make. We need policies that reinforce price transparency, support local manufacturing, and promote alternative distribution channels to make insulin affordable and accessible for all. Third, empower communities and strengthens primary care. A people-centered approach is essential. I have seen how community-led programs empower individuals with diabetes to take control of their health. Healthcare providers need training to offer holistic, person-centered care, and grassroots advocacy must be supported to ensure diabetes education is available at the primary healthcare level. Fourth, addresses gender and socioeconomic barriers. As a woman with diabetes and a mother, I know the challenges we face. Delayed diagnosis, limited access to care during pregnancy, and the burden of managing diabetes while fulfilling caregiving roles. Policies must be gender sensitive, addressing the impact of poverty, cultural barriers, and social expectations on access to care. No woman should have to choose between her health and her responsibilities. And fifth, advances research and innovation for inclusive care. We need research that addresses disparities in diabetes care, particularly for underserved populations. Digital health solutions culturally sensitive education and community-based interventions can bridge existing gaps, ensuring that innovations reach those who need the most. Achieving these goals requires more than discussions. It requires action. Government, international organizations, private sectors, and civil society must work together in urgency. Political will, sustainable financing, and accountability are essential to ensuring that no one is left behind. I stand here today not just as an advocate, but as someone who knows what it is like to depend on access to care. And I know that we can do better. I urge every policymaker, advocate, and leader in this room to take bold steps. Let us commit to a future where access to diabetes care is no longer dictated by wealth, geography, or gender, but it is guaranteed as a fundamental right for all. Together, we can build a world where diabetes care is equitable, accessible, and sustainable. Thank you.
Thank you very much, Ms. Anita Sabidi, for your keynote intervention representing the voices of people with lived experience. Thank you very much, Dr. Guy Phones, representing the global perspective of the WHO. We have entitled this show, this symposium, Improving Access to Care, a Strengthened Global Policy Framework. So if we go 5 years back in time, we did not have the Global Diabetes Compact, and we did not have the Global Diabetes Coverage Treatment Targets. Now we do. But at the end of the day, this will only be valid if we reach a nationwide scaled-up implementation. And the objective we had of this symposium when we designed it together, IDF and WDF, was and is today to show what's going on at country level. So we will have 2 panels now. The first panel will be about implementation of diabetes and NCD programs at the national level. And we have invited 4 representatives from 4 different parts of the world: Uzbekistan, Argentina, Tanzania, and Aruba in the Caribbean. They will each give a country case profile of their work. They are members of the IDF, they are member associations, and they have also been supported by WDF for a while. The first speaker we would like to invite to the stage is Dr. Nilufar Ibragimova, from the Charity Associations of Persons with Disabilities and People with Diabetes in Uzbekistan. And Dr. Nilufar is accompanied by the colleague from Georgia. Sorry. Yes, thank you very much. Please proceed with your presentation, and let's all speakers, we appeal to be very mindful of time. Thank you very much.
Добрый вечер, дорогие друзья. Я выражаю большую благодарность ВДФ и IDF за оказанную честь выступить перед вами.
Good evening, dear friends. I want to express my deep gratitude to WHO and World Diabetes Foundation and to IDF for this opportunity to speak here.
Миссия нашей организации – это прежде всего улучшение качества жизни людей, больных диабетом, и защита их интересов.
So the mission of our organization is to improve the quality of life of people with diabetes and improve the quality of care provided to people in Uzbekistan. Next.
Вы видите реализацию 4 проектов от Всемирного фонда диабета и реализацию грантов, которые мы получили от парламента Республики Узбекистан.
Here you see the list of the projects that were implemented in Uzbekistan. 5 projects are World Diabetes Foundation projects. 4 of them were successful and implemented at the 5th in the progress at the moment. And 2 grants received from the Parliament of Uzbekistan in 2021 and 2020.
Эти проекты направлены прежде всего на профилактику, раннюю диагностику и снижение осложнений диабета.
So all these projects are mostly aimed at the improving of quality of diagnosis, prevention, and increase in the rate of diabetes complications.
Благодаря реализации данных проектов мы снизили ампутацию в 2 раза и снижение слепоты в 2 раза в нашей стране.
So due to the implementation of this project, the rate of amputation and blindness due to diabetes was reduced twofold in Uzbekistan.
В январе этого года, 2025 года, мы получили грант от ВДФ по первому типу диабета, который направлен на улучшение контроля диабета и качества жизни детей с диабетом в Узбекистане.
In 20, this year, in 2025, the grant from World Diabetes Foundation aimed at improving the self-management and control in type 1 diabetes was.
Наши основные партнеры – это прежде всего Министерство здравоохранения Республики Узбекистан.
So our main partners, first of all, the Minister of Health of Uzbekistan,
который оказывал большую поддержку в реализации всех наших проектов.
The Ministry of Health supported implementation of all mentioned above projects.
Также являются партнеры это Центр кардиологии, Центр эндокринологии и региональные эндокринологические диспансеры.
Besides, our partners are the Center of Cardiology, Center Republican Center of Endocrinology, and regional endocrinology dispensaries.
Благодаря реализации этих 4 проектов мы фактически в Узбекистане добились улучшения ранней диагностики, профилактики и снижения осложнений диабета.
Implementations of 4 mentioned projects gave us the opportunity to improve the quality of prevention, increase the diagnostic rate, and the reduction in complication rates. And besides, the quality of care provided at the primary care level was improved also.
Значит, в 2024 году мы при поддержке получили грант от Всемирного фонда содействия сахарного диабета первого типа, который финансирует Panoramic Global.
So in 2024, a grant for the support of the type 1 community and sponsored by Panorama Global was received.
И успешно начали реализацию в 2024 году.
In 2024, the implementation of the project was initiated.
Вы видите количество медсестер, которые мы провели обучение в прошлом году.
So here on the slide, you see the number of nurses that were trained during this project. They are more than 3,000 nurses trained.
И провели 3-дневное обучение молодых от 18 до 35 лет больных сахарным диабетом первого типа.
Besides training of more than 2,000 young people with type 2 diabetes in self-management training, where in self-management and control was carried out.
Я хочу поблагодарить Ассоциацию грузинскую, которая оказала поддержку в проведении этих семинаров.
So Nilufar Ibrahimova wants to thank Georgian Diabetes Association that helped Uzbekistan Association in carrying out these workshops for people with diabetes.
Я хочу сказать, что основное наше направление и основная наша деятельность направлена на первичное звено.
So our first the goal, the group that we are aimed at is the primary care level.
И сейчас указ нашего президента, который фактически обращается, чтобы первичное звено, диагностика, лечение проводилось специалистами на высоком уровне.
So under the recommendation of public health, the primary care physicians should just be responsible for early diagnosis, prevention, and control of diabetes on a high level, high quality.
Спасибо за внимание.
Thank you very much.
Thank you. Thank you very much, Dr. Nilufar. We just heard from Umid from Uzbekistan, and we continue our world tour to some countries to hear success stories and challenges. Allow me now to present Dr. Silvia Lapertosa, Commission of Institutional Relations, Sociedad Argentina de Diabetes. Bienvenida, doctora. The floor is yours.
Thank you very much, Jackie. And thank you, the World Diabetes Foundation and the IDF, for inviting me and our organization to share with you our experience. To change the slide. Here. Green. Green. Isabel. Yes. Okay. The prevalence of diabetes in our country is 12.7%. Is continuing to rise with the epidemic of obesity. Implementing diabetes program within a national strategy for non-communicable disease is very important for improving public health outcome. The history of our organization, Argentine Diabetes Society, began 35 years ago with the approval of diabetes law in 1989, where together with the Association for People with Diabetes, we participated. 10 years later, the National Diabetes Commission was created, and shortly after, the National Diabetes Program was implemented. A strategic alliance between scientific societies, Association of People with Diabetes, university, government agency, and civil society organization is developing standard guidelines and various diabetes care strategies. In 1922, as a scientific society, we actively participated in the development and approval of a standard for the supplies of medication and supplies for people with diabetes. This covering 100% of public and private health sectors. This includes all kinds of insulin, metformin, and all kinds of medication to diabetes, insulin infuser, and continuous glucose monitoring, and they cover 100% of treatment for complication of diabetes, and include the education in the law. The WHO strategy for diagnosis and management of type 2 diabetes was implemented. This strategy provides guidance on the diagnosis, classification, and treatment for type 2 diabetes in a single document applicable to the entire Argentine population. The National Diabetes Commission, together with numerous scientific society and various health jurisdictions, our country have 24 provinces, has developed clinical practice guidelines on type 2 diabetes, microvascular complication, diabetic food, recommendation on the diagnosis of gestational diabetes and of cardiovascular risk factors such as obesity and high blood pressure. As president of the Argentine Diabetes Association, I participate in the food label law and in our country's functions. One of the great strengths of the Argentine Diabetes Association is the continuous work that has been done over several years with various government administration. It is important to highlight that this program has been implemented in different provinces. The Argentine Diabetes Society, together with 5 universities, offer courses for primary care physician, 7 diabetes diplomas for health team, and a master programs in diabetes with 14 practice centers all over the country. Associated with university, non-governmental organizations such as IDF, World Diabetes Foundation, Minister Association of People with Diabetes, and others carry out programs to promote health lifestyle focusing on controlling the obesity epidemic and promoting diabetes care at all health levels, like the following programs. The IDF Kids Project focus on controlling the obesity epidemic, particularly childhood obesity, besides educating teachers and students in type 1 diabetes, mainly in action against hypoglycemia. The Sing That Teach program for deaf people has set up the first clinical in primary care in the province of Mendoza. We support with Novo Nordics the Dulce Mowico program, named like this because in Spanish is the initial of each of the Aboriginal community. This program is a very important one because it allows screening, diagnosis, care, and education in the population with great difficulty to access. With the support of the World Diabetes Foundation, the project's comprehensive approach to strength prevention and care for vulnerable population within the public health system in Argentina for women with gestational diabetes, pre-diabetes, and type 2 diabetes is being carried out with 3 academic institutions, which our society collaborated closely. In this project, women with gestational diabetes are educated in workshops with educational material designed for the project, a digital book, 7 short videos, and up to date 1,075 women were educated in 11 maternity wards in 9 provinces. 3 massive open courses were held for the community with more than 9,000 participants. Through these projects, the health team was training through virtual platform of university and face-to-face. We have developed an easy-to-read guide for type 2 diabetes. This application has been validated with autistic children and people with low educational level. The good news, finally. The context is promising for going on working together with the support of the university and the Argentine Diabetes Society. Clinical practice guidelines, motivated teams, and the implementation of telemedicine allowed the expansion of the program, but it's not enough. Why? Because 6% of people with diabetes are undiagnosed. Half of those diagnoses have no treatment, and half of those treatments don't have good metabolic control. The turnover of health authority and some political change are causing some cuts in healthcare. We have high rates of comorbidity and low annual screening coverage to prevent complications. These challenges us to rethink strategies for assessing that is available, achieving greater commitment from government authorities and involving more stakeholders in addressing the challenges. We believe in what we do, and we are sure that we will achieve it. Thank you.
Thank you very much, Dr. Lapatosa. So we've been in Uzbekistan, we have been in Argentina. We will now go to a country which for many, many years has been supported by the World Diabetes Foundation through the Tanzania Diabetes Association, which has been a member of the IDF for many years. Please, Rachel Nungu, the floor is yours.
Thank you, Ben. Good evening. I'm Dr. Rachel, a program manager from TDA, Tanzania Diabetes Association in Tanzania. And I'm here on behalf of Professor Kaushik and Professor Swai to talk about the role of TDA in implementation of the National NCD program together with the Ministry of Health. And thank you so much, WDF and IDF, for this opportunity. Next slide, please. So we start talking about Tanzania Diabetes Association. This was founded more than 30 years ago, and it was founded by people who had interest in diabetes, who came together after seeing that the rise in diabetes in the country, and decided that they have to join hands, that they could advocate for better care and prevention of diabetes in the country. And over years, it has been evolved, and it has been implementing a number of projects, including the National NCD program, Phase 1 and Phase 2. We have Diabetes Food Program, National Type 1 Program, National Diabetes Compass, Acute Care and Emergence Program. All these have been supported by the World Diabetes Foundation and others that have been, we have other programs that have been supported by other funders who have seen our work and have joined hands in supporting us. So through all these projects, we've seen that there are a number of challenges of NCDs in the country. Next slide, please. And these, if you look into the health system building blocks, there are different challenges that we are facing in our country. For example, in the service delivery, there's service availability, accessibility, as most people, especially in the peripherals or in the primary lower level, they've difficult challenges accessing the quality of NCD services, including prevention, as most people are not aware of the NCDs, but also in the health workforce, and now a majority of the workforce, they have little knowledge on NCD prevention, and so there was a need for more trainings, but also the staff attrition. Today you train these healthcare providers, but then the next, you come next day, they've been moved, they've been shifted to other units, so that it's very difficult maintaining the workforce who are knowledgeable on NCDs, and also tax shifting. As we know that in the world now, doctors, they're not only performing work that's supposed to be done by doctors. So there's that tax shifting, which has also been a challenge. And in terms of health information systems, there's a challenge, as if you don't have a quality, a systematic information system, you find that patients may be diagnosed twice within the same region, within the same area. So that makes it difficult to get correct data on the number of NCD patients that are in the country, and so forth. So we have a number of different challenges in financing, in leadership, and NCD is a multi-sectoral, it needs multi-sectoral approach. And if you don't have the support from other sectors, it's very difficult for you for one ministry or for one sector to work on NCDs. Next, please. So over the years, TDA has been collaborating with Ministry of Health in Tanzania to make sure that we are trying to minimize these challenges, so that first we decrease the burden of NCD in Tanzania. As according to WHO reports, over 34% of deaths are due to NCDs in Tanzania. And this has been alarming, and has been a wake-up call in the country, so that we have to do some intervention on NCDs. As before, we used to work more in the communicable diseases, HIV and so forth. So now we are faced with double burden of the diseases, and NCD has been on much rise, and this has made difficult for the nation to progress in terms of having a quality of care. So that has made it its mission to make sure that we improve in prevention and service provision for NCDs. So in terms of leadership and governance, through the NCD program, we've managed to launch the NCD unit at the Ministry of Health. This was launched in 2019, whereby we have a special section in the Ministry of Health where there are staff there who work on the NCDs. And over the years, we've noted that they started with maybe 2 staff members in the NCD unit, but over the years, there've been an increased number of staffs. That shows that there's that commitment within the government to make sure that the NCD issue is well tackled in the country. We've mentioned the state member of parliament who take the NCD issues within the parliament, and we've managed to have the subcommittee within the members of parliament. Initially, it used to be just HIV, TB subcommittee, but now they've included NCD so that they talk about NCD within the parliament of Tanzania. So make sure that we have enough budget on NCD to make sure we are accountable on NCD prevention. And we have also managed to capacitate the leaders within the regional and district levels to ensure that there's supportive supervision and follow-ups of NCD's activities, even at the ground level. In terms of financing, there's advocates for universal health coverage. As in the previous, only 8% of Tanzanians were covered by National Health Insurance Fund. This made it impossible for everyone to have access to NCD services. So now we're advocating for universal health coverage, and we've also managed to strengthen the healthcare system, healthcare force, including the health information system. With the healthcare force, we have been able to train a number of healthcare providers from the national level up to the primary level, where more than 6,000 healthcare providers have been trained on NCDs, including diabetes, so they can provide care, including prevention. And they have more knowledge on the risk factor so that they can advocate for NCD prevention within the community. But also there have been issues of access to medicine, the essential medicine for NCDs, especially the insulin, with more efforts and with more efforts that are done in the country, we've been able to support more than 6,000 patients living with type 1 diabetes that are in different clinics. Previously, we used to have only 33 clinics, but now we have 83 clinics within the country. And all these, they've been supported by different partners, including CDIC and the Left for a Child, whereby all these clinics, they are also being supervised by Ministry of Health, although they're in different parts of they are in different levels of healthcare. As you can see there in that small diagram, in the pyramid of the healthcare system in my country, from the community up to the national level, we've managed to provide services from the national, regional, district to health centers. So all these they can provide NCDs. They can provide NCD care. And now we have managed to even have insulin at the lower level. Previously, we used to have only insulin at the upper level, up to the level of region level, because they could have a place to store insulin. But due to the necessity of having insulin even at lower levels, we've managed to influence the government. So now through the chief pharmacist office, they've managed to make sure that insulin is also available at the lower levels. And next, please. And on the health information systems.
1 minute, please, Rachel.
Okay, so as I talked about the strengthening of data collection system, previously it would be scattered at different levels. There are different levels of data collection systems, but through the advocacy and the ministry, I've seen the need to have one collective information system that can make sure that there's no double counting of patients with NCDs, but also to make sure that patients have followed up. In the future, we are looking forward to have the unique identity number, but currently we are making sure to have that patients, they can, all the systems are integrated so that the one patient cannot be registered twice. And on service delivery, we've managed to make sure that the availability of services, including the equipment, from the national level up to the lower levels, to ensure that at the national and tertiary levels where they receive a lot of complications, they need to have those equipment such as funders that can make sure that they screen for these complications. But at the lower level, we've managed to screen patients. We've managed to screen the people from the community, where more than 40,000 people have been screened on NCDs. And after screening, they've been referred to health facilities where they enter the health system so they can get better treatment from there. The next, please. So they can get better care
This
from
is the final slide, correct,
Yes,
Rachel?
yes,
please.
that's the final slide.
Thank you very
So,
much.
yes. Okay, so but then what have been the good monitoring mechanisms so far that has enabled TDA to work, the Ministry of Health to take up the NCDs? We have the National Steering Committee, whereby we have which has been chaired by CMOs, Chief Medical Officer, which enables that all the projects that all the programs that are on CDs are reported to him, to him or her, and they're all being regulated at the ministerial level, but also have enablers that ensuring that there's a good NCD movement, prevention movement in the country. For example, the government political will, as you can see, the government has been willing to take NCD under its capacity, to make sure that they're increasing funding on NCDs and they are having a lot of awareness programs within the country, but also they've been collaborating with different stakeholders to ensure that the NCDs prevention and activities are widespread. They're not even concentrated in one region. Now they ensure that all regions, with 26 regions of Tanzania, they have access to NCD prevention and management. And lastly, with funding from different international donors, but also the government has also been increasing this budget on NCDs. For example, even right now they have increased their budget by 15%, where they are doing the NCD prevention, but also they are also working on purchasing different equipments that are being used in NCD prevention, such as fundoscope, fundus cameras to all 26 regions in the country. And lastly, I would like to appreciate the strong leadership of Tanzania Diabetes Association through Professor Kaushik and Professor Swai that have been ensuring the sustainability of NCD prevention in the country. They want to make sure that the government is on the front. We always make sure these programs are not owned by TDA. They are owned by the government to ensure that there is that strong commitment from the government. Thank you so much.
Thank you very much, Rachel. And we would also like to thank the government of Tanzania to have taken a strong leadership in the NCD response and building those multi-stakeholder partnerships that we heard from Dr. Guy before. We have a next speaker in this first round, and we will be very mindful of time. Please also, we have a question and plenary question session at the end. Please keep your questions to the end closing session.
So as we continue our Diabetes World Tour, I came up with this just now, and this creates a commitment bent as I suggest we do more of these sessions. We have many countries being active, and it's not fair to hear from few countries only. So maybe we do this on the road to the UN high-level meeting in New York, right? And we can include the WHO support with us, so we will be putting hand in hand together. So our jet continues now to Aruba, as we will hear from Ms. Nourian Arias. She is IDF Young Leader in Diabetes and mentor from Aruba. The floor is yours, my dear Nourian.
Thank you. Thank you very much. Thank you for the opportunity. I'm very excited to be here and to represent Aruba, a Caribbean island, pearl of the Caribbean to be exact. I just wanted to mention that I am indeed a young leader in diabetes mentor at the moment for the North American Caribbean region. However, I also wear other hats like PhD student, patient, and also part of the commission that advises the government of Aruba on healthcare in Aruba. This is very recent. So before I can explain how we have managed to push advocacy and also participation in civil society organizations, I would like to explain what we have been doing and how we have achieved what we have achieved so far. So to start, what we have been doing recently on the island is transitioning to a more collaborative and integrative collaboration process and system on the island. There's presence of intersectionality. We have a multicultural, diverse community. And that means that everybody has a different background, social economic status as well. We are not considered a low income or middle income country, to be exact, but we do have some social challenges on the island. So that means that we do a lot of hands-on projects to make sure that those who might be considered vulnerable have access to information, education, and also tools to self-manage their diabetes or any other non-communicable disease. It also means that we have a lot of intensive guidance and contact through medical care is one, through guidance, through nurse practitioners, and many other projects that we have developed, such as awareness and education campaigns. So going to the civil society organizations and patient participation, I will use the example of the National Diabetes Foundation, Fundación Diabetes Aruba in Papiamento. So recently, the most important roles of the foundation has been to share information, make sure that it's correct information through the most prominent channels that have the most contact with our patients and community, and to also establish little communities within the context of diabetes and NCDs, and to also encourage promotion of advocacy and patient sharing information and peer sharing. Why do I mention this to be exact? As a small island and in a small context, we may imagine that because of the high contact, information reaches very quickly. However, we do experience challenges with a lot of stigma and also shame. And because we have this high contact and because it's a small context, everybody knows what is happening with you. And it's quite counterproductive and it is contradictory, but it seems to be something that has been prominent and we're trying to fight as we go and as we collaborate more and more among our medical care system providers and professionals and our civil society organization. One very successful example of Fundación Diabetes Aruba project is the PRISMA. It's an adaptive education program from the Netherlands to Aruba, where patients with diabetes type 2 or individuals with type 2 diabetes could share their experience but also learn self-management tools. And after the months of intervention and also education, have become more self-confident and have more intention to self-manage their condition. Another example is a medical adherence project that was conducted in Aruba and Curacao, where again, the most prominent topic that moved forward and came forward was the self-confidence once again. Hence the reason why we must continue collaborating and raising awareness through all channels. So how can we continue improving our care? We should continue providing more guidance, but also consistent guidance through nurse practitioners, specialized nurses, and in order to enhance follow-up and monitoring through our professionals, but also peer-to-peer support. Another point is the patient environment and empowerment through education programs and interventions that we continue developing, but actually must be consistent. And for one reason or the other, social challenges, but also political challenges have been challenging to continue consistently. And the last one, and very important, is research, not only in Aruba, but regionally. Our sister islands like Curacao and St. Martin, Bonaire, I can mention many more. We can learn a lot from each other. We are more alike and similar than we think, and that is a strength. And that is something that we are trying to benefit from in all senses of the word, learning from each other's practices and understanding where we come from. At the end of the day, some of the islands are part of the kingdom, and contextually, we can see each other in many similarities. So if I can explain in a nutshell, we try to organize projects with twofold objectives, never just to impact the patient, but also to collect data and understand the context better every time, and in order to improve our systems and our programs. So in a nutshell, thank you very much. And what we have learned, in short, is consistency, contact, and collaboration, but most importantly, care. Very much. Thank you very much.
Thank you very much, Ms. Nurian. So we've been to Uzbekistan, to Argentina, to Tanzania, and to Aruba. We say the time is now, time to act is now, but certainly a lot of action has been ongoing, is ongoing, and that gives us all the hope that more can be done and we can achieve the targets we have set. But we have a second panel, and we would like to hear this time in this second round a bit more reflections from the speakers about the Global Diabetes Compact that was introduced earlier by Dr. Fones, and the speakers will reflect on their work in light of the aspirations of the Compact. The first speaker is Professor Abdul Basit, who is the president of the Diabetes in Asia Study Group, please. And the second?
And I would like to say first, hold on to your questions on the first panel. We will give the floor for that. If you don't want to forget, put them on your phone. Write a note on your phone so you keep them for us later. Our second speaker of this panel is Ms. Lucía Feito Allonca. Please come to the stage. We will have our speakers being seated here at all times of this panel.
And we have Ms. Osarengo Echima from Nigeria, from the Blue Circle Voices movement of the IDF. And finally,
Professor Alicia Jenkins from the IDF Western Pacific.
But we will start with your presentation. A few slides. Please be very mindful of time, Professor Basit. You promised me to be very concise of time, and you were allowed a few slides, so please go ahead.
Otherwise, we're going to be very strict because we want to respect time.
We also would like to have time for questions at the end. Thank you very much.
Clock on, then 5 minutes from now. Thank you, the chairpersons. Yeah, my job is to tell you about diabetes in Asia. What are we doing as regards global dynamics? We know about the IDF vision, so I would not read it out. We have heard about Global Compact, the 6 components, and the 5 targets given. Why Asia specifically has been invited? Because 6 of the 10 top countries for diabetes, as numbers, higher numbers, are in Asia. So in 2007, these 2 visionaries, Prof. Shera Late and Arun Bakshi, they thought of developing diabetes in Asia study group. These were the think tank at that stage. Now I'll be having 4 topics in it. One is like prevention. So prevention first in Pakistan, in Bangladesh, they are doing tremendous work. China has got a blueprint. Turkish society, arrest diabetes. Indonesia, we have heard of it. And then India. So prevention ought to be the first thing we need to do. And as the Global Compact is coming for treatment modalities, etc., primary prevention still stays the main or the cornerstone. Next is technical work. What in Asia are we doing? So we had this Journal of Diabetology. I was the first editor of it. Right now, editor-in-chief is V. Mohan. And you can see at a glance that how many authors, reviewers, manuscripts are generated at the Journal of Diabetology. We are very proud to say that we take special issues out, like for gestational diabetes, for diabetes care in IDF MENA region. We talk about 100 years of insulin. We do not talk of 100 years of glucagon. We had a special issue for glucagon, etc., etc. And this JOD is not only getting popular in Asia, but across the globe, we are getting manuscripts now. Coming to partnerships, we are proud to have partnership with WDF, long-standing, not only for Pakistan, but in Asia. This is a project right now called Changing Diabetes in Children. We are training in Pakistan for type 1 diabetes, have centers working together. Iram Ghafoor, yesterday elected as IDF Vice President. And we have 3,000 children right now enrolled in Pakistan, getting free insulin, free HbA1c, etc. done. Where we work, 30 partner countries. And as you can see from Asia, there are a long list of countries which are partnering it. Right now, we are in the process of developing a national level and then global registry for type 1 diabetes. Harvard University is on board to help us out. And Bent knows we were a few weeks ago in Copenhagen, and we were discussing how to go about it as regards insulin and insulin for type 1, accessibility, affordability, all across Asia, all across the globe. Finally, about advocacy, we know about these sugary drinks and the taxes. We in Asia had a campaign. This is our Journal of Diabetology covering a position statement for advocacy that sugary certain beverages should have taxes. We have seen good results in India, in Philippines, in Saudi Arabia with it. What are the future prospects for us? We like to conduct studies. We invite all, not only from Asia, from all over, to conduct studies to characterize the state of diabetes within Asian regions. We yesterday heard Peter Shavas talking about type 5, which is our problem, type 4, which is majorly our problem, regardless of type 2, which is our main problem. To promote the publications of activities and formulate the national and regional guidelines, to ensure the participation of governments and NGOs, and to pursue active collaboration with national and international organizations such as IDF, WHO, WDF. I finally would like to memorize this Professor Akhtar Hussain, who was the past president of DAS and IDF. Thank you all for your attention.
Thank you. We appreciate you sticking to the time. This is unlikely with Professor Basit. He usually tends to take extra minutes. So as you can see, we continue flying our World Diabetes trip, our tour. So we will now hear from Ms. Lucía Allonca. Let me just briefly inform the audience that you will discuss the potential of the Global Diabetes Compact from the perspective not only of type 1, but also of type 2 diabetes. And in Argentina and Spain, 2 countries at the same time. Have you seen a plane landing in 2 countries? Here you go. The floor is yours.
Hello, everyone. It is a great honor and a pleasure to be here as a Blue Circle voice representing the countries of Argentina and Spain to discuss the Global Diabetes Compact and its 80-80-80, 60-100% coverage targets, a framework that has the potential to change the life of millions of people living with diabetes. But how? What are these numbers? What do they mean? Well, the Global Diabetes Compact aims for 80% of the total people living with diabetes to be effectively diagnosed. 80% of those diagnosed have very good blood glucose control, glycemic control. The world is challenging control. As people living with diabetes, we can say that a better word could have been management, but we will go into that later. 80% with good blood pressure levels beyond the glucocentricity, checking other parameters. 60% of people living with diabetes over 40 years old to be receiving statins. This is the preventive side. And the most important one, 100% of people living with diabetes effectively having access to affordable insulin and blood glucose monitoring so that they can achieve the results they need to thrive, to feel good. Why is this important for people living with diabetes? When we live with type 1 diabetes like me, early and timely diagnosis is just essential because if the diagnosis is not doing in a timely manner, we risk our lives due to a possible diabetic ketoacidosis. So, early prevention, early diagnosis is a must. And now we are seeing so many screening programs taking place. So we have the possibility to detect type 1 diabetes even before it shows the first symptoms. These screening programs are changing everything. And there are even drugs available to delay the onset of diabetes. The targets related to the complications are affecting also people living with type 1 and type 2 diabetes. And that's why we want to maintain a blood glucose management that is as optimal as possible, because that's going to change the outcome of our lives, how we feel every day. Everything changes, the future and the present.
1 minute, please.
Please.
And also, it's very important that we have access to everything that we need. So, it's important that when we are designing policies that are about us, about people with diabetes, we must be at the center of the decision-making table, creating policies for people with diabetes, by and with people with diabetes. And not just people with type 1 diabetes, not just people with type 2 diabetes, but everybody coming together for a unified advocacy voice. So in these times of polarized and uncertainty times, it's an invitation for all of you to take these coverage targets and make a reality out of them. No matter that you're a person living with diabetes, a policymaker, a healthcare professional, or an advocate. Thank you.
And the word will now be yours. Sosa Renko, you're also a Blue Circle Voice member, but from Nigeria. Please, your reflections, what we heard about the compact, and from your experience as a person with lived experience. Thank you. 5 minutes, please.
Yeah. My name is Osanhoi Ethel Chima Wongugu. I personally live with type 2 diabetes for 25 years, a member of the Blue Circle Voices. and also a member of the Global Advisory Committee for NCD, and also I run the NGO, Diabetes and Limb Salvage Foundation. As I stand here, I can't stand here to just speak about Nigeria alone, because Nigeria, we are 200 million, but we set the pace for Africa. I stand here on behalf of other African countries, so I can speak again alone for Nigeria. 4 years of Global Diabetes Compact. I was there from the beginning. It's like it's a project for me, and I owned it. The impact, I've lived with diabetes for 25 years. I lost both my parents, I've lost both my brothers, I've lost friends. But the best time of my life is since 4 years. See what WHO Global Diabetes Compact is doing. When they launched it, I was there, and I've been with them all through. And it has changed the world for diabetes. And I thank IDF, World Diabetics Federation, what they have been doing in working in collaboration with Global Diabetes Compact Forum. It has changed Nigeria for the better. We are moving towards positive change, even though the struggle is huge. I'm very hopeful. And I want the whole of African country, like I have been doing the campaign, that every NGO, institution, individual, you have the interest. Diabetes is what brought all of us here. We can make that change. I was happy to hear my two sisters here describe how far they've gone. Diabetes is not a death sentence, and WHO has our back. And with this launch, which we did 4 years ago, we are celebrating 4 years. And I would like to thank Guy and Bente for a great job they did. So it has changed Nigeria and Africa. We are moving towards a very, very progressive. I know insulin is a challenge. Before, when I was diagnosed, insulin was not something I could talk about. But today, I'm giving out insulin. I'm supporting those who do not have. I know our political situation in Nigeria and across Africa is not very good, but we are moving. I don't see the problem. I seek solution. And that's why I'm here, to celebrate these 4 years with WHO and with all of us. So I would want to say that this problem is not just ours alone, it's all of us, and that's why we are here. I would like to say thank you to World Diabetics Federation for making this possible today. Like you promised, we are taking it to UN, and we're going to do more of this. And I hope those of us in low-income country, when they are giving us a voice to speak like this, getting visas is a challenge. I hope WHO will support us to make it possible that we are there to continue this struggle and this support. So the change is positive, and I'm very hopeful, and I know my children are not going to go through what I went through, and the future that we're sitting here with us. I say thank you, congratulations, and happy anniversary to all of us, because I know we're going to do a lot better. Thank you very much.
Thank you so much. Well, thank you, Ozarenke. Actually, what I said was a proposal, an invitation, not a promise. Now we have a commitment to make that promise. Okay, so as we continue, coming, unfortunately, myself from a very conflictive country that has known a lot of humanitarian issues, I would kindly ask Professor Alicia Jenkins from Australia to let us know a little bit about the humanitarian situation. The floor is yours, Professor.
Thank you very much. So I've been working with Insulin for Life for 25 years and collaborate with other NGO organisations. And we do disaster response. But given that 90% of the people in the world today with diabetes live in less advantaged regions, everyday life can for them be like a disaster. But of course, then when a disaster does come along, such as COVID, which is still ongoing, that derails many healthcare systems and the best laid plans of many. And it takes away costs, resources, it kills a lot of people, including a lot of the healthcare people. And whilst I think the goals of the Global Compact are fantastic, and I would love to see all of them met, I look at them and think, wow, would definitely like to see that. But then I think, shoot for the moon, and if you miss, we'll still end up among the stars. We've got to go for it. The quality and the quantity of life of many people today and the next generations are dependent on the success of these sorts of initiatives. I'd like to see, I think, at any given time, there's always a few disasters, natural disasters and man-made disasters that hit the news. There was Palestine, Gaza. We're hearing about the earthquakes in Myanmar and here in Thailand. But if you look at the website called Our World in Data, at any given time, there's often 50, 60 wars or civil unrest going on. And also then many natural disasters, often with less warning and with often years for recovery. So they will derail these fantastic plans and these initiatives, but deferring them is okay. Stopping them is not. So I think it does need to be considered. Perhaps there should be a subcompact statement there about how to deal with disasters. But we know that if a community, a country is better prepared, then it weathers and comes through disasters, be it man-made, better. So it is going to take a global village, and you've got it, and I'm really impressed in seeing and hearing what has been going on, and no doubt more will continue. As the IDF President Peter Schwartz has said, we are all the IDF. We are all the IDF and a part of the initiatives by the World Health Organization, UN, the Global Compact. Don't just sit up and watch. It's what you can do. We've got a diverse people, young people living with diabetes. We need individuals, communities, families, healthcare professionals, policy makers. It takes many, many organisations, and the Global Compact is a fantastic roadmap. There will be bumps in the road, but we'll get us there, and if it's late, it's still going to be great. Thank you.
Thank you very much, Professor Jenkins. We have now been through the two panels. We had a keynote intervention from Dr. Guy and from Ms. Sabidi. We had introductory remarks by WDF and IDF. Now is the time for questions from the audience and also the online audience before we proceed to our closing segment. Yes,
if we may ask, please, to be very brief with your question, and the reply maximum 90 seconds. If you kindly abide by that, it would be wonderful.
And one question per participant or per audience. Yes, please.
We've been good with the time so far. Let's continue with the trend.
And before we have the question, I wish to say that just after the event, we have a small buffet or light serving outside. Please join us after the session for a bit of networking. Yes, please, let's have the first question.
Well, first of all, I want to congratulate all the speakers. And,
please say your name and your...
Manuel Vera from Cuba.
Yes, please.
I want to congratulate all the speakers because they have done a very great work, but they have not mentioned the first thing they do. That's education. And education is the one has done all what they have to do. And I think it's very important to keep on giving education, because education will have advocacy, but education will have all the rest. And in matter of disaster, we have in Saka region a group of disaster that has made a webinar, has made a lymphograph, has made a lot of things that are we are agree with as Alicia has done.
Thank you. That was more a comment, I suppose. That's also fine. Next question, please.
But if I may say, there was comments about education in what we heard. Training nurses is an educational program. Training physician is. Everything is technically related to education.
Let's proceed with the question, please. We had a question from... Yes, your name.
I'm Shabin Naz Masood, Professor of Obs and Gynae from Pakistan. I have a confusion since a long time, and my question is to all the people sitting here, including our panelist, Professor Basit, that we have been advocating, we have been teaching, we have been training, but every year, after every 2 years, we hear that diabetes has reached from 500 million to 800 million. So why is that so? Are we not reaching the patients? Are we not advocating properly? Or is the disease very notorious? Or are we screening more? I don't know. So I often ask this question, that why are the numbers escalating every day, every year, in spite of so many things going around?
Could we have a panelist response here, please?
Yeah. That's actually part of my project, how to drive down the figure. And it's because we've not been addressing, we've not been involving those with the lived experience. We just started doing that, the IDF, WHO, and CD, they just started involving people with the lived experience, inclusion. And also we've not been doing prevention, we've been doing management, is what the world has focused. So it's prevention. Take it to them from the school level, from the young age. IDF has started diabetes in school, capture them young. So from that young age, you're preventing, you're teaching them everything. So for the next, from now to the next 10 years, I'm sure the figure is going to go down. And also we have to get the government involved so the policy will change. I was in Kigali and I saw what happened there. And then it was Japan also did a presentation during World Diabetes Compact launch. They said what they have done. They changed policies. They went back to the roots, involved children from the young age. So you see the figure going down. That's how we all are going to do it. I think that's basically what I know and I'm believing is going to work. Sorry? Yes, and management, support, family support, get your family involved, and the government.
Yes,
A couple of other
thank you
aspects
very
to
much.
those.
Another question here, please. Can we have the microphone?
Sorry, just
Okay,
another-
please. Yes, sorry,
Okay.
Professor Jenkins.
Another couple of, as to why the numbers are growing. The success of your screening program, primary prevention is good, but for type 1 diabetes, it's impossible to prevent it. But the growing numbers of people with type 1 diabetes mean that they're surviving. So see that as a success.
Good evening, everyone. I'm Dr. Nilesh Kapoor. I am from New Delhi, India. And I'm also Government of India's Technical Expert Group Committee member for diabetes. What I've seen in my experience is that the prioritization about NCDs is pretty low if you look at the priority of the ministries. And one of the primary reasons for that is an overdue focus on the SDGs. The way the SDGs has been constructed, the focus is more on maternal child health. So don't you think it is time to kind of bring NCDs into the focus, because the reference to SDG which I was seeing was pretty indirect in terms of diabetes. So what happens in that is, because the focus is on maternal child health and this via SDG, the diabetes is very indirect, the prioritization is taking a back seat within the ministry itself. So don't you think we need to concentrate our advocacy efforts around this?
Yes, and are you directing your question to a panelist or?
A comment.
Okay, please.
Okay, I would like to answer to your comment that if you look at the SDGs and the subgroups under the SDGs, they are all interconnected and interrelated in a way that if you tackle SDG, and this is my area, if you tackle SDG number 3, which is about good health and well-being, what do we all want? Whether it is diabetes, hypertension, cancer, any NCD, we want the person to have well-being. You cannot have well-being without having good health and good mental health, physically and mentally. Something else, when we say about zero poverty, zero hunger, if we have poverty, we have more diseases. So please look at the SDGs as an umbrella to tackle health from whichever perspective we want.
Thank you, Jackie, for the intervention. Next question from
It's
Dr.
not a
Kapoor.
question, it's a comment to Nilesh Kapoor. The fundamental issue of primordial prevention lies with maternal and child health. So if we want to reduce the burden, so I'm not too surprised that or agitated about the fact that maternal and child health is receiving attention. Without that, we will never be able to bring this curve down.
Absolutely.
Thank
We
you.
have a question
We have a
here,
question.
Beatrice, please. Professor Misbah.
Okay, we also welcome
Yes,
brief
yeah,
comments,
just in
please.
short,
Brief
yes.
comments, brief comments.
Yes, the health system in all our...
Sorry,
our-
where are you from, sir?
From Egypt.
Egypt, thank
Msbah
you.
Kamel from Egypt.
Yes, please.
Chair elect of Egypt. The problem that the health system is still going in the underdeveloped countries for the acute care, not the chronic care. So we, for a long time, neglecting the NCDs and what is related to it. So it is going up. Now is the time to act. So this is maybe the key point that we must address.
So it's a great title. The time is now.
Yes.
And I would say it was
Yes,
yesterday.
thank you. We have a question here, please. And one behind. Okay, we go behind first. Then, you'll be next, sir. Okay, please go ahead. And your name and your origin, please.
Ramaz Kurashvili from Georgia, member of IDF. We know very well names of enemies, diseases, war, cold heart of healthcare providers. And the media also, some media is an enemy, ignorance is an enemy. We need new friends. For example, in Georgia, we have a first lady, our friends of people with diabetes. Georgian parliament is a very good friend of people with diabetes. What about in your country, for example, in Pakistan, who is the #1 friend, new friend only? Spain, Argentina, Nigeria, Australia. Alicia is the great friend of, very great.
Sorry, what's your
long
question,
time.
sir? Your comment, please? You have a question
Yeah.
to the panel?
Yeah, question. Name of our supporters, new supporters.
Question? Or you're suggesting?
Yeah, what do you know?
Okay.
Pakistan.
Like my country, the new minister of health.
Not Georgia.
No, I'm talking
Nigeria.
about my country, Nigeria. My president, my new minister of health, is very NCD friendly. And last month, he just gave an approval for a budget, and not just budget. He gave approval for them to provide point of care for people living with diabetes and other NCD, which we haven't experienced all my life of living with diabetes. I've not heard that before. So he's very friendly, and that's why I'm going home with confidence that I have something to discuss with him. So that's about Nigeria. And Ghana too. I've had the Ghana government is very friendly and supporting. So we are having very progressive move coming to Africa. When I told you that Africa, WHO is changing our word, Global Diabetes Compact, I'm serious about that. So I'm sure next year you will hear something different.
Thank you, Ozarenkib. Let's please, Dr. Basit, keep it to maximum 90 seconds.
And any other questions from the
Ramaz,
floor?
you asked
Yes.
about Pakistan. So in Pakistan, for the first time ever, with our advocacy, with all these programs, etc., we had the concept paper approved by the government for 6.8 billion rupees, first time ever in the history of Pakistan, to be given for diabetes. It's only last week.
And the next question here from, yes, your name and designation, sir.
Professor Bishir from Bangladesh. My question is to Dr. Guy from the WHO. In your
Dr. Guy,
presentation,
yes.
In your presentation, you mentioned about the 80% people with diabetes are diagnosed. How can we achieve this, especially in the low medium income country where facilities are not exist?
Please, Guy.
You have
You
a
have a mic
microphone.
right in front of you.
It's on.
Right, it's on. Thanks for that question. I think it's each of these targets we have to really unpackage them. That is a very interesting advocacy piece. We present the 5 coverage targets, but behind each of these targets is a broad portfolio of guidance frameworks and ongoing activities to ensure access to those to medical products that can ensure the screening, the early diagnosis, and we have ample guidance on how we're evolving and how we're supporting countries address additional tools and screening options that can really help us fast track to those targets. So I encourage you to access those QR codes. where behind each of those targets, again, there's a portfolio of products and tools and support that we can access, and we are delivering those at country level, we are contextualizing those at country levels, and we're understanding additional context and challenges to some of those early screening and diagnostic challenges.
Thank you very much, Guy. And Professor Elton, please.
Thank you. I'm Mohammed Al-Toum from Sudan. I think it is the last minute. It could be the last question. And very hot one, opening eye. Global Diabetes Compact is a creator, has been created by WHO. And WHO now, as a result of Trump withdrawal of fund, is it on the intensive care?
Yes, Guy, please.
We'll address that question because it's probably...
It's on.
Yes. The impact of any financial decision by member states on WHO, we will address, and we do address. In this particular situation, we have to really understand what is our core business. How can you continue, protect, and prioritize the core business of WHO? I can confirm that the Global Diabetes Compact, its implementation, its adaptation at regional and country level is a core business of WHO, and we count even more on collaborations and partnerships to make this happen. But it is completely prioritized as core business of WHO, and please be confident that we will be with you, with regions and countries supporting the implementation in all of its phases.
So, it is more a comment than a question. So I'm Elena Shelster, already from Georgia. So my comment is that when we are talking about the impossibility to reduce increase in new cases of diabetes via education, because the approach of patient education is not correct, especially in still healthy population. It should be motivational education. And there were wonderful programs that really could help, like Eli Lilly program supported by IDF, the Novartis program supported by Peter Schwartz. So if farm companies, the World Diabetes Foundation, and International Diabetes Federation help to create these motivational programs that then we will study and will implement, I think we will just a very good thing for the future.
Thank you very much. And we have time for a final question before we go to the closing segment. Any final question from the floor?
I can add something. I want to add something.
Yes, there's a question at the back, and then you can add in the meantime, please. Please go ahead, Osarengo. Please go ahead, yeah.
I just wanted to add something that Global Diabetes Compact Forum, you can, because of the question the man at the back asked, you can register institution, your NGO, you can register and be part, because WHO wants every country to own it. So NGO, government institution, hospital, if you know you are doing something on diabetes, or whatever you are doing, please register and be a member of the WHO Global Diabetes Compact. Then you own it, you'll be participating. And then when they start the execution, your country would be involved and be in control. I just wanted to add that. Thank you.
Thank you very much. We will have the final question from the floor, please. The final question, and your introduction, please.
Yeah, thank you so much. My name is Oren Umbiro. I'm from Kenya, working with Medtronic Labs. So my question is still to WHO. So we are seeing these ambitious targets, quite good. But is there a mechanism for holding countries accountable to these? I know they are voluntary, yes, but how do we nudge countries to actually push towards achievement of these targets? So that's one. And then two, we know how the data systems...
One question only, please.
Okay.
Please.
Thank you.
That's
Thank you
already
so
a
much.
lot. Please, Guy, your remarks.
Yes, very quickly. Excellent question, because it is time to act, and how we measure the actions we have taken will depend on... There we go. It will depend on strong accountability mechanisms. First and foremost, we are working with countries to understand how to measure that progress across those achievable coverage targets. These are achievable, ambitious, but achievable. And again, we have a portfolio of resources to support the achievement of these. But also we need to ensure that we are measuring, countries can measure progress into and beyond 2030. And for that, we are developing excellent examples of how to support countries in defining baseline estimates from where to build on their progress. But also we count on civil society partners to help us on that accountability, advocacy for accountability, holding our partners accountable, holding WHO, holding member states, holding partners accountable. That is one of the leading roles of civil society, of lived experience. We call on you to ensure that you also have your accountability frameworks on the ground in communities and can ensure that this is progress, this is real progress.
Thank you very much, Guy. And I think we should give a round of applause to the panel. Please, panel 2, you are welcome to step down and take your seat. For the closing segment, we have invited you, Guy, to give a few reflections. We have invited Dr. Kapoor of the WDF board, and also yourself, Jackie. Please take a seat. Yes, please. We have a few minutes left for reflections of the session. And as I said, just after the session, we have some light food served outside. But we've been through a tour of the world. We have heard about the Global Diabetes Compact. We've heard from people with lived experience. We've heard some very impressive country cases from Uzbekistan, Tanzania, and Argentina, and Aruba. And we've had a very interactive session with many questions. And I guess taking us through all this in less than 100 minutes is quite an endeavor, but it also shows the encouragement and the commitment that we see from so many stakeholders worldwide. So having heard all this, Guy, and having presented the Global Diabetes Compact to us here when we started the session, what is your reflection from all this? How do we reach those targets? And what is your takeaways from today? Please.
Difficult to summarize, actually, because it's such an impressive discussion, such impressive insights. But probably that is probably one of the main takeaways, the global tour. The global tour is so important. It's transcendental to understand the value of initiatives like the Global Diabetes Compact. And in that, I'm delighted to see that the Global Diabetes Compact is alive and kicking and enhancing, expanding and strengthened, and it's touching base on regions and countries, and it's being implemented effectively and effective. But also, countries are identifying challenges, gaps, implementation gaps, contextual issues that are impeding additional progress. And I think this is interesting. The global tour is an interesting insight on how countries, even above and beyond the Global Diabetes Compact and its framework and its targets and its implementation models, countries are already progressing. I think we've got excellent, amazing examples from countries, from countries, how they are dealing with this whole of systems approach, the life course, the policy development, the advocacy moments, the implementation frameworks, and they're also, while demonstrating progress and successes, they're also identifying some of the challenges to continue with that progress, to fast-track progress into 2030 when we have to demonstrate those targets. So, and good to see that some of those challenges are being addressed by the work of the Global Diabetes Compact. So it's not necessarily that we want a top-down approach where we have the GDC and we want that implemented, contextualized, and then addressed at national and subnational level. It's how we meet, the bottom-up and the top-down, how the Global Diabetes Compact meets with the successes at country level, how both can be adapted and talk to each other, and can demonstrate sort of how we can pinpoint some of those processes. But very much we need to learn and fertilize the Global Diabetes Compact with those lessons learned from the ground. So I'm going to take on your promise, your commitment, both of yours commitments to continue with the global tour, because we need more of those insights, and how we can continue adapting a very dynamic process, which is the Global Diabetes Compact. So congratulations to all who presented. It was really impressive, the successes on the ground. I think we can learn so much, and we can continue adapting, as I say, our WHO policies, programs, and services, and the initiative itself from what we're learning from you.
Thank you, Guy, and also many thanks for your statement earlier on here, some minutes ago, about the commitment to the Global Diabetes Compact from the WHO itself. Now, we spent all these years building it, launching it, targets, World Health Assemblies, all this work. We cannot let it go now. We have to move on. Anil, you've been with the WDF for quite some years, and you followed the progress
since it was born.
Since it was born, 23 years ago. But a day like this, you hear all this, all these country stories. It must give you hope that we are moving in the right direction. Am I right?
Yes, Bent. I think it's about time. And of course, in an audience like this, we all know what the challenges are. We know we live in a very complex world with a lot of uncertainties. And when we talk about these challenges and problems, we drain our energy and we bring ourselves down. I'm so excited when I hear about the successes. With very little money, with very little resources, we are trying to transform and we are bringing about a massive change. That excites me. I think we need to talk more about these successes. I made a mistake. I realized many years ago when I used to talk and say diabetes is so expensive and all that, I realized I have to turn it around and say not treating diabetes is very expensive. Not preventing diabetes is very expensive. Okay? And that is how we need to do. If we keep talking about challenges, you think our ministers will want to get their necks into a challenge? No. When we showcase them what is being done, and it can be done, and it doesn't need mega bucks to get it done, they will all want to be part of it. And that is what we need to do. We need to showcase what has been done and what can be done. And that excites me. So to me, this was a fantastic thing. And in WDF, I live this high every day. Because when I read reports from our projects, I get so excited. When I talk to our program managers, I get so excited. Let's do this now. Let's do that now. Because that creates that excitement. So I think we need to turn things around, not talk so much about, we all know what the problems are. Even the patient groups know, even the young leaders know, we all know. In this group, let's not do that. Let's up our energy and talk about successes and what can be done.
Thank you, Anil, very much for your inspiration to all of us in WDF and to the audience. I'm sure everybody can see the commitment and the aspirations that we share. Last but not least, Jackie, now you are in the closing panel and you're going to give closing remarks. Thank you for the co-moderation. I think it went extremely well.
It was a pleasure.
But now I'll turn you into the other role with the final remarks for today.
As I always say, I'm very well in front of the camera and behind the camera as well.
And now you are in the front of the camera.
Yes.
Now you are in the front of the camera.
Right?
You
So
are,
we can
in
do
fact,
the Oscars.
you are literally in front of the camera because we have 600 or more people online. So this will be the final words of this session. Please, your perspectives on the session today and the future ahead of us, IDF, World Diabetes Foundation, WHO, and all these many stakeholders who are here and those who are online, the unity onwards towards 2030 and how we can achieve the targets. Please, Jackie, a few final remarks from you.
Thank you so much. This is a huge responsibility. I will have to say that we are at a crossroad, definitely. On one hand, we have more technology than ever, more resources than ever, more international organizations than ever, and yet we see the numbers on the rise. If this is not a call to action, please tell me what is. And I would say, let's not create more organizations. The Global Diabetes Compact is excellent. I'm looking forward to joining efforts. I would suggest right now, you will say she's the queen of suggestions. I am also the queen of action. So I should suggest at this moment to create a diabetes front. Let's forget the names of our associations and have one goal: to work for those living with diabetes in every little community in the third world countries, in the first world, because they face sometimes the same challenges. I want you to go from here out of the sessions with 3 ideas in your mind. We need to translate the ideas into actions. We need to build the strong policy. This is not poetry, it's action. every one of us can knock on the door of the ministry, have a meeting with the minister, let them know what we are doing. They may not hear us the first time. Be insistent, be persistent, be perseverant. I found many closed doors, even at the IDF when I first joined, and look at me now. I am the walking example that perseverance gets you somewhere. And we want to be somewhere, not for us, not for ourselves. We are here with a responsibility to serve those living with diabetes. And as the mother of a daughter living with diabetes, I carry this as a mission, not only on my shoulders, in my heart as well. And the third thing, we need to mobilize resources. So this is a call to all of us, and I speak here for IDF, to all of us. Let's do this diabetes front. All of us, put hand in hand, collaborate together, join the efforts to give a better quality of life to every single person living with diabetes. And if what we heard today is something, it's a hope, it's a light at the end of the tunnel called diabetes. We've seen bright numbers, we've seen great actions, we heard success stories, yes, with challenges, but I still find it hopeful. So we have hope, and each one of you should walk out of these doors with a determination. I have to do something. Put your next goal in front of you. Think of the people living with diabetes. Carry them in your heart. Carry them in your mind. In every word you speak, we are here with a responsibility. This is a privilege, but also a big responsibility. So let's do it, and the time for it is now.
Thank you. Thank you very much. This was the closing of the session. Could I ask all the speakers to come to the stage? We'll have a group photo, please. And otherwise, please go outside. They're serving. And thank you for attending the session.